speaker today is Dr. Miranda Wilhelm, Clinical Associate Professor at Southern Illinois University Edwardsville School of Pharmacy and Community Clinical Pharmacist with Schnucks Pharmacy. Dr. Wilhelm received her doctorate of pharmacy from the University of Kansas School of Pharmacy. She completed her community pharmacy residency at B&K Prescription Shop. And prior to her current positions, Dr. Wilhelm was the pharmacy manager at Hen House Pharmacy in Kansas City. And in that role, she was also primary preceptor for the Hen House Pharmacy, University of Kansas School of Pharmacy Community Pharmacy Residency Program. Her areas of interest include self-care initiatives, disease state management and education, wellness and preventive screenings. She also enjoys mentoring residents and students to assist with their professional development. I also want to report that Miranda Wilhelm does not have any actual or potential conflicts of interest in relation to this CPE activity. And now, Dr. Wilhelm.
Thank you. Good evening, everyone, and welcome. I would like to wish everyone a happy holiday since it's that time of year before we get started. And then we'll kind of roll into our learning objectives. So upon completion of this continuing education activity, pharmacists should be able to recognize how point-of-care screening tests differ from diagnostic testing. That will be an important point for us to discuss. Then we're going to spend some time talking about CLIA-waived tests and the requirements to utilize CLIA-waived tests in a community pharmacy. And our last objective is to describe how point-of-care screening tests can be used within the community pharmacy as part of an innovative practice model. So I wanted to start off the presentation by kind of trying to prove that pharmacists are going to be needed to do point-of-care testing. So as everyone knows, healthcare reform is very big and a big hot topic. And because of healthcare reform, a lot of patients are going to have access to healthcare that have not had access before. So we're going to need potentially more healthcare resources to be able to accommodate the patients that are new to healthcare. And there have been several groups that have tried to estimate if we'll have enough healthcare resources with this influx of patients, and they have found that we're going to end up with insufficient healthcare resources. And according to the Health Resources and Services Administration, which is a federal group, 20% of patients currently live in an area with an insufficient supply of primary care physicians. 16% live in an area with insufficient dentists, and 30% live in an area with insufficient mental health providers. So this has proven that we are going to have a shortage of primary care providers as a result of the increased access to health care. And the Association of American Medical Colleges says that the shortage will be about 45,000 primary care physicians by 2020. So we're definitely going to need more physicians to help care for these patients that now have gained access to care. So some information about pharmacists. It's estimated that there's around 225,000 active pharmacists in the United States in 2010. Compare that to the number of primary care physicians that we have of 208,000. As well as physician assistants at only 30,000 and nurse practitioners at 56,000. So there's plenty of pharmacists to be able to aid these other healthcare providers. And then we're all familiar with there being a community pharmacy on every corner. And the last count was somewhere between 59 and 67,000 community pharmacies in the U.S. So hopefully this is quickly confirmed that there would be a need for pharmacists to be able to perform screening and wellness activities to help reduce the burden on primary care physicians and other healthcare providers. So it's an important topic for us to discuss. So point-of-care screening is defined as tests designed to be used at or near the site where the patient is located that do not require permanent dedicated space and that are performed outside of a laboratory. So these are meant to be fairly simple tests that don't need lots of test tubes and laboratory space and equipment. The equipment needed is fairly simple to use and fairly compact in size. It's important when we're talking about point-of-care screening that we discuss the difference between screening and diagnostic test results. So sometimes with tests you might get numbers. With cholesterol, you can get like a total cholesterol of 200 and an A1C of 7. So you could actually get numbers. But it's important for us to remember that pharmacists cannot diagnose disease states. That's the role of the physician. Pharmacists can interpret laboratory results, but we would never be able to say, you have diabetes because I did an A1C and it's high. We would always need to refer those patients to their physicians for maybe follow-up testing and confirmation of that result. Another thing to think about is reactive versus positive. So a screening is not a diagnostic test, and so that means we can't say that a patient tests positive. We would have to say that their test was reactive, which sounds like kind of a similar answer, but they're different. So, and some of the tests that we're going to talk about are not considered diagnostic, and that's where the reactive would come in. So instead of saying you test positive for HIV, you would say your test was reactive for HIV, and then that means that you need follow-up tests and confirmation and diagnosis by a physician. So it's important for us to differentiate screening and diagnostic tests. The other thing that you want to think about, too, before you offer these services in your pharmacy is what will you do if someone gets a reactive result. So you may not want to be the person that says you reacted to HIV, which now means that that patient could potentially have HIV infection, and you're the first person to give them that news. Then how are you going to comfort them? How are you going to care for them? What referral process would be in place so that they can see a physician to get treatment for that disease state? So also consider that prior to discussing test results with patients and performing these screening tests. So this is a list of diseases with common point-of-care screening tests available. Of course, we know diabetes and high cholesterol are highly prevalent, so I didn't think that I would focus on those as much this evening, but rather talk more about some of the kind of infectious agents. So hepatitis C may be a newer disease state for some pharmacists. As many as 1 million individuals in the United States have undiagnosed hepatitis C virus infection, so it is very prevalent. It's the leading cause of liver cancer and liver transplants. And more recently, the CDC, Centers for Disease Control and Prevention, made a recommendation that all individuals born between 1945 and 1965 needed to be screened for hepatitis C. So a lot of primary care physicians are worried about how they're going to meet this screening requirement, because that is a lot of patients that have never had hepatitis C screening that are now going to need that test. Human immunodeficiency virus, or HIV, may be more familiar with that disease state. It's estimated that 240,000 patients are undiagnosed with HIV in the United States. And again, the CDC made a more recent recommendation that everyone in the U.S. be tested for HIV at least once. And there's some specific recommendations related to pregnant women and other things like that. But this is just a blanket. Everyone in the U.S. needs one HIV test during their lifetime. And that is a lot of patients that have not had HIV tests that need it. So an increase in access to this is going to be really important. And again, primary care physicians have been worried about how they're going to meet this requirement because it's so many people. Also, as community pharmacists, we probably have a lot of information about influenza and strep throat. So we'll be covering those this evening as well, but I don't think we need to discuss the impact and importance of these disease states. The next part that we need to spend time talking about is CLIA. And CLIA stands for Clinical Laboratory Improvement Amendments. And this is really important to read and follow if you're going to be doing any laboratory testing in your community pharmacy. And I have found that a lot of pharmacy schools do these things behind the scenes and they don't tell their students about them, so you may not be aware of this requirement. So it's really important to be up to date with this. So CLIA was an amendment passed by Congress in 1988 and was fully implemented in 2003. So it's taken quite a while for this to be able to become fully recognized. The amendment establishes quality standards for all laboratory testing to ensure the accuracy, reliability, and timeliness of patient test results, regardless of where the test is performed. So this includes tests in laboratories and hospitals or other laboratory-specific companies, as well as those tests that we'll be doing in community pharmacies that we're going to talk about this evening. So it covers both regular laboratory tests and then the tests that we're going to talk about, which are considered CLIA-waived tests. The requirements for CLIA are based on the complexity of the test, not the type of laboratory that's doing the testing. So it has to do if the test is simple or complex, if its ability to be CLIA-waived or not. And kind of the negative part of CLIA is that this combines both federal and state requirements. So it is a federal program, and the federal program is the ones that writes the regs and oversees the requirements, but it's also a state program because the state implements and enforces the requirements. So you do have to deal with both kind of state and federal regulations. So what is a CLIA-waived test? And that's defined as a simple laboratory examination and procedure that have an insignificant risk if an erroneous result is obtained. So for a test to become CLIA-waived, the manufacturer actually has to request this status, and this is approved through the FDA. So it's kind of a hodgepodge of government agencies that are required for a test to become CLIA-waived. You can make a list. You can see a list of CLIA-waived tests at the website that I've provided, and if you do a Google search for CLIA-waived test, you can find it very easily as well. The one thing, kind of more general to CLIA that I want to also mention is that it's important to check the package insert of any test that you're considering offering to make sure that it specifically spells out in the package insert that that test is a CLIA-waived test and that it's approved to be used as a CLIA-waived test. Some manufacturers make tests that are both for regular laboratories, like in a hospital, and tests that are CLIA-waived, and so you have to make sure that you're getting the test that's CLIA-waived. If not, then you'll need to apply for the regular CLIA that would be like a hospital laboratory and not the CLIA-waived laboratory. So moving on to kind of some more specifics about CLIA. You may wonder, how do I get this CLIA waiver? So each individual site, so if you are in a chain that has multiple pharmacies, you are going to have to apply for a CLIA waiver for each site. And a CLIA waiver is basically a certificate that comes mailed to your pharmacy that says you can perform tests that are CLIA waived, so you don't have to have the full laboratory approval for like a hospital lab would have to have. There is a form that you have to fill out to receive a CLIA waiver, and it's called the CMS 116 form, and you can find that on the CMS website that I've given the link to here, or you can just do a Google search for CMS 116 form and it pops right up. You have to fill out the form and then you have to mail it into your state agency. So this is where the federal and state starts to cross over, and so you have to fill out the form and then mail it into your state agency, and there's a list of addresses that are associated with that website to help you find who to mail it to in your state. The fees for CLIA could potentially change, but they've been stable for a while. So it's $150 per CLIA waiver. And there may be associated state fees in addition to that, so you may want to check with your state as well. And then you would renew your CLIA waiver every 2 years. So it's $150 every 2 years, which isn't too bad. In addition to these kind of get my CLIA waiver, you also need to follow documentation requirements. So to maintain your CLIA waiver, you have to follow the manufacturer's instructions exactly on every test that you perform. If you happen to change the instructions or do something out of the package insert for that test, then it's no longer considered CLIA waived and you're not authorized to perform tests that are not CLIA waived. You have to perform quality assurance procedures or QA checks prior to doing any screenings as the manufacturer suggests. If you do not perform the quality assurance measure, then it's no longer considered a CLIA waived test. You also are potentially open for audits by CMS or a state agency auditor. This is not required and it doesn't happen like every 2 years with your renewal. It's random inspections. And I know my School of Pharmacy has a CLIA waiver for our student organizations to perform screening tests, and we were audited last year. So they do come. And then you also may have to have protocols or standing order sets depending on your state. And then in my state, we actually do have to have a protocol because lab tests are considered a prescription. So you have to have a physician sign off on your ability to perform the screening tests. So there's a question mark beside that one because every state may vary. I've worked in other states and we didn't have to have a protocol. So it's important to contact your state agency to find out any additional requirements besides just completing the CLIA waiver to be able to perform screening tests. And that's how I found out we had to have a protocol. So I want to move on to specimen collection, and we're going to talk about these 4 different types that are potential options for point-of-care testing. So whole blood, oral fluid, nasal swab, and a throat swab. So the technique for whole blood collection, the first thing that you want to do is always tell the patient what you're going to do and what to expect. Because some patients have anxiety related to needles and the Lancet devices to obtain a finger stick for a blood collection. So you want to just let them know it's, you're going to feel a little pinch and then it'll be over, kind of what to expect. We want to have the patients warm their hands. You can instruct them to rub their hands together to increase blood flow. You can have them wash their hands under warm water, or if they could hold on to like a warm cloth to help increase blood flow. That will help you in your collection of the sample. Then you want to make sure to wash your hands, and you can do that. It's best to do soap and water, but if you only have access to the hand sanitizers, those would be fine as well. And then it's important because of blood-borne pathogens that you put on gloves afterwards, and always use gloves for any whole blood collection. Then you're going to clean the site on the patient's finger with an alcohol swab and allow to air dry. Don't fan it or blow on it. And then you're going to apply the lancing device and activate it to perform the skin puncture. And you want to perform a deep puncture so that you don't have to squeeze the finger too much. That introduces extracellular fluid, or milking the finger can introduce extracellular fluid. So try to do a deep, firm puncture. Most tests instruct users to wipe away the first drop of blood with a gauze pad, and that's because the first drop of blood may contain skin cells from the lancing device being pushed through that spot, as well as potential extracellular fluid from any rupture of the cells. So wiping away that first drop of blood will kind of reduce contamination. And then a gauze pad is important instead of a cotton ball, because it needs to be a non-linting gauze pad. So if you think about when you get a cotton ball on your finger and it pulls the cotton ball out and it kind of has all that lint associated with it, this will not allow for the blood to form a drop. The blood's actually going to run with that cotton stuck to your finger, and so it'll be harder to collect the sample. So a gauze pad will not do that. It will stay intact. You don't have to worry about the blood not forming a drop. And then if necessary, you can gently squeeze the finger, apply some pressure to facilitate bleeding. You can also have the patient hold their hand below the level of their heart to facilitate bleeding as well. I'm sure most people are pretty good with their finger stick technique. And then this is just a picture of someone who is performing a finger stick technique, and they are filling a capillary tube. So I thought instead of talking about glucose and cholesterol, because most pharmacists are familiar with that, I would talk about the OraQuick hepatitis C virus rapid antibody test, which uses blood to collect the sample. So the items that you would get, and I should point out that I don't have a preference for the OraQuick. It's just one of the ones that's available, so I thought I would show it, but there's many others that you could use instead, so you don't have to be biased related to that. Devices that come with this include the test developer solution in a vial, a reusable test stand, a specimen loop for collection, so this would be different than a capillary tube, and then the testing device itself. And so what you do is you collect your blood sample, perform finger stick as we just discussed, and then you use the specimen collection loop to just collect a little drop of blood. You place that collection loop down into the developer solution, kind of swirl it around to mix the blood up, and then after that time you would place the testing device with the flat pad down into the developer solution, and then each test has a different amount of time that it has to stay in contact with the solution. And it uses capillary action on that pad to wick the solution up into the device for the antibody test part to be read. And then you would read the results after the amount of time has relapsed. And this will be one of the ones that we state whether the patient was reactive with the test or if they had no reaction. So on the left-hand picture of the screen, you can see the C for control and the T for test. And both have pink line beside it, which if there's a pink line beside the control means that the QA within the test was successful, so that means that the results are accurate. And then having the light pink line beside the T means that they tested reactive. So if there was nothing there and a pink line at the C, then it was non-reactive. But it's important to point out the other two pictures on the right-hand side is that the darkness of the pink does not matter. So you don't have to have a firm dark pink line to be considered reactive in the control or the test. If there's a faint pink line in either, it is also considered reactive. So make sure that you're familiar with how to interpret the test results once you have obtained those as well. And the darkness of the line doesn't mean like, oh, you just barely tested positive. If it's a light line like on the very right-hand side picture, it still is reactive. So the darkness of the line has no indication of how positive or negative they were. So moving on to oral fluid collection technique, it's important again to tell the patient what you're going to do and what to expect. So this is going to be taking a sample from their gums, so that's not as scary as maybe a finger stick might be. Going to ensure the patient hasn't had anything to eat or drink or used any oral care products like toothpaste or mouthwash for a specific period of time prior to the test. And that varies based on manufacturer, so it's important to check the package insert prior to performing the test. Then you want to wash your hands and put on gloves before you perform each screening test. Have the patient tilt their head back slightly, and then hold the swab to collect the sample in your dominant hand and hold the patient's lip a little bit out away from their mouth with your other hand. And then you're just going to run the swab across the patient's gums on both the top and lower gums. Just one time all the way across. and then the top, and then all the way across the bottom. And that's all you have to do to collect the sample. So I have a picture here, and it's not as good because they're not holding the patient's lip away from their teeth, but in stage 1, you can see where they have the pad that's going to collect the sample. Then in picture 2, they have it placed between their cheek and their gum. And then in picture 3, they're running it along the top of the gums above the teeth. So that would be how you would do it. And then you'd also want to do the bottom gums as well. So a test that we can talk about for oral fluid collection is the OraQuick HIV 1 and 2 rapid antibody test. And this supplies with it the solution again to develop the test, the little vial stand that you can set it in, and then the device itself. And this actually looks very similar to the hepatitis C test that we just did previously. They're very similar, but the hepatitis C one used blood. You can also use oral fluid with hepatitis C detection. It just depends on the test that you're using. And then this HIV test can use oral fluid collection as well. So with this one, you would take that device itself with the little pad on the end and run the pad all along the gums, both top and bottom, and then you would place it into the developer solution and let it sit for a specific amount of time that it'll state in the package insert. And then you'll interpret the results, and I have that displayed on this slide. So you would collect your oral fluid sample in step 1, and then insert the device into the solution, and then you would wait 20 to 40 minutes, and then you would read whether the test was reactive or non-reactive. And here's kind of a blow-up of what that screen window looks like, so you can kind of see. On the left-hand side, we have the control line and the test line, so we know the test worked, and they're testing reactive. You can see there's a little difference in color between the lines, like the darkness of the pink line, but that doesn't matter as long as you have a line there. That's the important part. And then on the right-hand side, you can see we only have a line on the control part, so we know the test worked correctly, but they are testing non-reactive because there's no pink line with the T results. So now we're going to test your knowledge. Which of the following specimen collection techniques is used to perform a point-of-care screening test for HIV? Is it A, the nasal swab, B, oral fluid, C, throat swab, D, whole blood, or E, B, and D, which would be oral fluid and whole blood. So if everyone wants to take a second and put in their response, we'll go over the answer in just a second.
Okay, Miranda. Miss Wilhelm, it looks like we've got most of the results in. And it looks like we've got 56% for B and D.
All right, good. So, excellent. Nobody picked nasal swab. We haven't talked about that one yet, or the throat swab. And the correct answer for this one is B and D. Both oral fluid and whole blood can be used for HIV tests. Good. I've got that highlighted there. All right, so now we're going to talk about the nasal swab technique. And again, you want to ensure that the patient does not blow their nose prior to the screening test, because we're going to be testing for influenza generally. We want to make sure that there is that mucus still in their sinus passages so we can grab those virus cells. Tell the patient what you're going to do and what to expect With a nasal swab, it may be mildly uncomfortable, but they shouldn't experience pain. It shouldn't be painful. You want to wash your hands, and then use of gloves is optional. In this case, you may want to follow what procedures the nurse practitioners or physicians do in your area so that you look similar to them for professionalism. But it's optional because you're using a really long Q-tip to obtain the sample, and your hand's going to be at the opposite end of the Q-tip as where the sample will be collected, and so the chances of you touching it are fairly minimal. Now, if you're worried about touching it, go ahead and wear gloves by all means. Have the patient tilt their head back and close their eyes. You don't want them to see you coming at them with the giant Q-tip. That will freak them out potentially. And then using your non-dominant hand, you want to hold the patient's chin to steady their head so they don't try to jerk away from you or move quickly if they happen to see the Q-tip coming at their nose. Then you're going to hold the swab in your dominant hand, and it's best to do it between your thumb and forefinger. And you're going to insert the cotton end of the swab straight into the nasal cavity until reaching the turbinates, which is about 1 inch. So you could potentially mark 1 inch with maybe a pencil on the end of the swab, trying not to touch the Q-tippy part too much, so you know how far in you need to go with the swab. And then gently rotate the swab slightly. Couple of reasons. One is that it does help to ensure that the swab collects cells and mucus so that you get a good test. But also you may want to wiggle it gently to squeeze it between the turbinates. So if you notice that you're hitting something and it doesn't seem to be going in for that 1 inch depth penetration, if you kind of wiggle it slightly, you might be able to move it so that it now is between the turbinates. And I have a good picture on the next slide to help show that a little bit. Okay, so before you freak out, the actual photograph on the right-hand side with the Q-tip picture, you can see how far it's going. That is way more than 1 inch, so we don't have to put it in that far. But I just love the cutaway parts. You could see how you're trying to fit it into the turbinate. So that is way farther than we would need to put the Q-tip in. 1 inch is all you need to put it in. So kind of going back to the cartoon description on the left-hand side, you can see those turbinates kind of above the Q-tip, and so if you were hitting one of those with the end of the Q-tip, it wouldn't be able to move forward. If you kind of wiggle it a little bit, you can change kind of the motion, and then that'll help to get it in between the turbinates where you want to collect the sample. And then you just rotate it a couple times around, and then you're able to pull it out. So for the test that I want to discuss for the nasal swab, it's the QuickVue Influenza A and B test. So again, there's many different influenza tests available. I just picked this one, so don't feel biased by this presentation. And the parts that comes with it are a special solution in the vials to do the developing of the test, as well as in the packets you can see those are sterile Q-tips that are long enough to penetrate the 1 inch that we're going to need for our depth. Then to obtain the test results, you're going to take the solution and pour it into a test tube. And then step 2, you're going to take your Q-tip that you have obtained a sample from a patient's nasal cavity and kind of swirl it around in that developer fluid for, it says 3 times, kind of swirl it around 3 times. Then you're going to wait 1 minute, leaving the Q-tip in the sample, and then you're going to swirl it around again 3 times, and then you're going to remove the Q-tip from the liquid. And then step 3 is you're going to insert the test strip into the developer solution and wait 10 minutes, and then you'll read the results. And the results will look like this. So we have, again, a test line and a control line. So on these tests, the blue line is the test to show that, or the control to show that the test worked properly. And then the pink line is the reactive or non-reactive for influenza. So you can see the top one has both lines, which means that it's positive. The middle one is a little bit less in color, so it says weak positive, but it's still positive. And then the bottom test has no pink lines, so that one is negative results. In our last specimen collection technique that I want to discuss is the throat swab. So again, tell the patient what you're going to do and what to expect. With a throat swab, a lot of people will have coughing or gagging, and so you want to maybe let them know you might gag and try to have them resist that as long as possible. If they're gagging, they could potentially bite down on the swab or kind of prohibit you from getting a good sample. So it's important to kind of get them to try to hold off on gagging as long as possible. And then wash your hands. Again, you're using a really long Q-tip to obtain a sample, so you're going to be at the opposite end of the Q-tip, so gloves are optional, but you may want to follow the same practices that nurse practitioners and physicians or other lab technicians use in your area so that you look professional like them. Ask the patient to tilt their head back slightly, stick their tongue out, and close their eyes. And you can see the more practice you get, you may want to have them say ah to help open their throat so that you can get a really good visual of their back of their throat, as well as make it easier to run the swab across those tissues. You can hold a tongue depressor in your non-dominant hand and then use the swab in your dominant hand. Make sure you are using the recommended swab for the test and not just a plain Q-tip. You don't necessarily have to use a tongue depressor. When I trained on how to do this procedure, I found if I had the patient open their mouth and say ah and stick their tongue out, open their mouth wide enough that I didn't need to use the tongue depressor. I could get the Q-tip in and perform the swab without even using the tongue depressor, but that's still an option. Collect the specimen by passing the swab along the tonsillar arches. Try not to touch the sides of the mouth, and you can go across and back, so 2 swabs to get an accurate sample. I've got a picture here of the inside of the mouth on the left-hand side, so you can see where the throat is swabbed. And so the part that hangs down in the back of your throat is called the uvula. And so you're going to take the swab and touch it right up next to the tonsils and then go across the tonsil arch. And if you want to hit the uvula, you can. They can't feel it when you do it necessarily. So you can hit that on the way over and then go all the way down the other tonsil arch and tonsil, and then you can go back across. And that would be all you need to do to collect your sample. And then the photograph on the right has the Q-tip and the tongue depressor used in the dominant and the non-dominant hand. So the tests that I have to talk about for the strep, which is what we would be testing for with a throat swab, is the QuickVue strep test, and that comes with a reagent solution and then a testing kit, and it comes with its own specific cotton swab that they want you to use. The testing procedures for these are first that after you collect the sample, you have to make sure that the cotton swab is inserted into the kit correctly. Then the reagent solution, you're going to, you can see there's a vial inside of a bottle, so you're going to squeeze to break the vial just one time and then allow those 2 liquids to mix. And then you'll quickly fill the well of the testing device, and then you'll wait 5 minutes, and then you'll read the test results. So with all of these test results taking a specific amount of time, it's important to know what the time is for each test, to know when you should read the test. And it's also important to have a timer so that you're not trying to check your watch. You need that loud beep to remind you, because you can set the test and then maybe go back and check some prescriptions, but you want to make sure that you read the test at the correct time or it won't read correctly. So after the test is done, you can see the picture on the left-hand side is a positive. So we again have the control line and the test line. And then on the picture on the right, it's negative because we just have the control line. And this one just has the strep A, but there are other tests that can do both strep A and other streps. But generally, this would be the most common one that we would see in the community. All right, let's try testing your knowledge again. Which of the following specimen collection techniques is used to perform a point-of-care screening test for influenza? Is it a nasal swab, an oral fluid collection, a throat swab, a whole blood sample, or B and D, which are oral fluid and whole blood? So if everyone wants to take a second and click in their response, we'll go over the answer in just a second.
Okay, Dr. Wilhelm, we have most of the results in now, and it looks like about 73% for nasal swab.
Excellent. That's the correct answer. Nasal swab is what we would use for influenza detection. Good job. And I've got that highlighted. Influenza is a respiratory disease, so it enters the body generally through the sinus passages or any mucous membrane. So the nasal swab is what we would use to detect it. So I put this PowerPoint slide together to kind of review the different point-of-care screening tests that we might do and then the fluid collection sample that we might use. So just as kind of going through a reminder of the different ones, we didn't discuss diabetes and cholesterol this evening, but you're probably more familiar with that test already, and that uses a whole blood finger stick sample for it. The next one that we have is strep throat, and so that's pretty obvious that it's going to be a throat swab to be able to detect that condition. The next one is hepatitis C, and this one uses a whole blood sample for testing. Then we have HIV infection, which can use whole blood or oral fluid, which we talked about earlier. So this one has two methods, whereas most of the other ones only have one collection. So with this one, it's important to make sure that you know which collection your test is approved for, because they look very similar. The oral fluid and the whole blood test look very similar. So it would be important to know which way the collection is approved for that specific test that you're performing. Just check the package insert for that. And then influenza, we just did nasal swab for that one. And just to review, all the different tests for everything. So the last objective for us this evening was to talk about how these tests could be used in an innovative practice model in a community pharmacy. I know a lot of pharmacies are doing diabetes A1Cs and cholesterols, but I feel like the rest of the list that we've discussed this evening, I think just offering those tests in your pharmacy makes you innovative, because I don't know very many pharmacies that are offering strep throat tests or hepatitis C, HIV, or influenza. There are some. I don't want to say there's none, but it depends on your state as to whether you can do some of these things. But generally speaking, this is not common practice in a community pharmacy. So if you're going above and beyond by offering these infectious disease point-of-care screening tests, I think that means you have an innovative practice model already. Some other benefits of offering these screenings in your pharmacy is that we can increase screening rates to identify chronic disease states. So we know with diabetes and high cholesterol that the sooner we can identify that a patient, it can help get them into treatment sooner, then that reduces their potential health care costs later on and helps reduce the morbidity and mortality related to the disease state. So that's definitely an important point for us to consider when offering these tests. It can increase referrals to other healthcare providers for chronic disease states or the infectious disease states that we talked about. And so you could gain some relationships with physicians by referring patients to them. That could also help those physicians refer patients to you for the screening as well. It could reduce the transmission of infections to susceptible patients who have chronic disease states. And what I'm thinking about with this bullet point is if you have a patient who has congestive heart failure, CHF, in the doctor's office for their annual appointment, sitting next to a patient who has influenza, they could get sick from the influenza patient who's waiting to see the doctor. And we really don't want our patients with chronic disease states to get influenza because they're the ones that are more likely to get put in the hospital or die from it. So it would be great to be able to pull that influenza patient to the pharmacy for testing because they probably already came into the pharmacy to get Tylenol or ibuprofen to treat their aches and pains from their influenza. And we could treat them so they don't have to be exposing those other chronic disease state patients at the doctor's office to that infectious disease. So physicians, once they catch on that you're helping and they can see that CHF patient and maybe work with them, they'll be happy to have you performing some of these screenings. It provides access to earlier treatment for infectious diseases and chronic disease states. So with influenza especially, you have to get Tamiflu started within 24 to 48 hours after symptom onset. So if you could just hop into a pharmacy and get screened and then maybe treatment right away, it would be quicker than maybe sometimes you can't get into the doctor for a day or two and you've already had symptoms for a day or two and now Tamiflu is no longer effective for the patient. So that would help earlier access to treatment. It provides data for pharmacists performing medication therapy management, MTM, and disease state management programs. So a lot of times in community pharmacy we may not have laboratory results. So being able to perform an A1C or cholesterol in the pharmacy gives us data to be able to make medication recommendations for physicians that are specific to the patient. And another one I think is important is patients should know their numbers, especially related to their chronic diseases. So this is a great way to educate patients about their numbers and what those numbers mean and what they should do in response to that lab data. Regards to treating their disease state, like taking their medications, following up with their physicians, and so on. All right, it's our last testing your knowledge question. Which of the following specimen collection techniques is used to perform a point-of-care screening test for strep throat? Is it a nasal swab, an oral fluid collection, a throat swab, a whole blood sample, or B and D, which is oral fluid and whole blood? So if everyone wants to take a second and click in their response, we'll go over the answer in just a second.
Okay, Dr. Wilhelm, I'm going to close the polling as we have most of the votes in for 96% for the throat swab.
All right. Excellent. That is very good. That is the correct answer for strep throat. We can easily detect that using a throat swab. And that's highlighted. Good. All right, we are now going to move into the question portion of the program. So if you have a question, go ahead and type it into the question box, and I will start answering. This is a great question from Jennifer. She said, since we don't have the authority or license ability to diagnose patients after seeing reactive lab tests, can we as pharmacists confirm non-reactive results are in fact non-reactive, or should we still just tell the patient to get tested again by their primary care physician? So this is a good question because you need to know about sensitivity and specificity of the test, and we didn't necessarily talk about that, but all the tests have in their package insert sensitivity and specificity information, which is the chances of a false positive and a false negative. And so most of these tests are designed that you would have like you wouldn't have false positives. So generally if it's reactive, it means that it's reactive. But we still want to have them do confirmation testing with diagnostic indicated tests to know. If the patient is coming to you and they're asking for an HIV test, then there's probably something going on that makes them think they might have HIV, or they could be concerned about that. So I still think they probably need to talk to their doctor because they're doing maybe some kind of risky behavior that could need some counseling, more so than what maybe we would feel comfortable providing as pharmacists. So if the results are non-reactive, you can tell the patient that it's non-reactive and that's what it means. And if they still have questions after you've counseled them on what non-reactive means, then you can still refer them to their physician. So Valentine has a question about, can a pharmacist be sued for negligence or malpractice for an error in a screening test? So there's many ways that this question could go. I think important things for us to think about this would be if you're performing the test within the recommendations of the manufacturer as specified and you've done the QA and you've done all the documentation, then you're performing the test appropriately. You can't be sued if you're doing it correct. The other thing that you would want to do is check with your liability insurance provider, because these are considered usually part of pharmacy practice, and as long as it's within your state practice act to perform point-of-care testing, then you're within the scope of your practice, not necessarily. Now, there might be other reasons for negligence or malpractice that I'm not thinking of, which could open a pharmacist to liability, but if it's within your scope of practice and you're following all the federal and state requirements, then you're covering yourself, so you shouldn't necessarily be concerned about legal issues. You still have to follow all of those rules. Oh, this is a great question. How about reimbursement for these tests, considering we don't have provider status yet? And that is correct. We didn't mention reimbursement at all for these services, specifically during the presentation. So you can try to bill these services to third parties. The people who have tried it so far generally have not necessarily been successful in receiving reimbursement because we don't have provider status. So generally these are patient pay, cash pay customers. And that's typically the reimbursement that pharmacists who are doing this are currently receiving. There is a question about reimbursement rates for pharmacists for the tests. And that you'll have to decide what your market can bear. So we don't necessarily want to talk numbers, but you'll have to look at kind of your cost to purchase the testing supplies and your time, and then come up with a fee structure based on what you think your market will stand. There's a good question about the throat swab, and that I stated to try to avoid the cheek, and just wanted to check on the reason for that. Is it to avoid cheek cells on the swab? For the throat swab, we're looking really for the back of the throat, and so it's exactly correct. We don't want to have contamination from other parts of the mouth, because you do have bacteria in your mouth all the time, and so we're looking for the bacteria that would be an infection is present and not the normal flora that's present. And those would be commonly found on your cheeks and tongue, so it's important to kind of stay away from those areas so that we can see the pathogenic bacteria causing an infection. Someone has a good question about how to bill for these services. Yolanda, thank you. So currently, to bill for these services, you would have to contact the patient's insurance to see how they would accept bills from pharmacies, if they accept bills from pharmacies. And generally, the way that they would accept that is on the CMS 1500 form. So it would be similar to, like, if you're doing immunization billing through the CMS 1500, it would be a paper claim. I don't believe that many insurances accept electronic claims for point-of-care testing from pharmacists, so you have to do the paper claim on the CMS 1500 form. But if you contact the insurance prior to submitting, you can find out any specific requirements that they have. Oh, this is a great question from Lee. If the patient tests positive or has a reactive test for Hep C or HIV, must we report to the state health agency or just tell the patient to be tested again in a hospital lab with diagnostic testing? And you do, if you are going to start doing some of these infectious diseases testing, have to follow the CDC recommendations for reportable diseases. And I believe HIV and Hep C are both reportable diseases, so you would have to set up some type of a protocol or a process with your health department to say that you got a positive test, and then you could refer the patient to the health department. Or you could set up an agreement with a physician where you would refer your reactive patients to that physician to have the follow-up testing done. It is important for us, the CDC keeps track of how many patients test positive for HIV and hepatitis and other disease states, other infectious diseases. And so you will need to follow those rules if you're going to start collecting those types of samples. Eugene, this is a great question. How does bleeding seem to be appropriate in a supermarket pharmacy with the presence of food? Actually, my practice site is in a community grocery store pharmacy. And I agree, you have to be very careful. So you're going to have to follow bloodborne pathogen protocols specifically, and I think it's best to have some type of a semi-private area so that you're not in the aisle with people in their shopping carts and food and blood and all of that stuff together. So some type of semi-private area that's away for privacy for the patient, but also to keep the blood and stuff away from everything else. And then cleaning is going to be really important, following the appropriate cleaning techniques related to blood in any environment. Somebody's asking, how long does the whole process take from the time the patient comes in getting results of a test? And that depends on which test you're running. So some of the tests just take 5 minutes, but other of them take 20 to 40 minutes. So you'll have to factor that time in for the test to run, as well as you're going to want to include consent forms and maybe screening forms in addition to that, and so the time that it would take to complete all of those paperwork as well. So it really depends on the disease state that you're testing for and additional documentation that you want to keep, but they can be, you know, as short as a few minutes to up to maybe 30 minutes or an hour.